So my team and I have been working on patient safety in family practice. And what we did was we recruited a number of family practices and we developed an incident reporting system, and we asked everyone in the practice to report any incidents that they found that could have or did harm a patient. And then every 6 to 8 weeks we'd go back into the practice to help them develop and to test a system change to decrease the incidence of those sorts of activities happening in their practices. This work is based on the work of James Reason, who is the grandfather of patient safety, who has shown that most things that go wrong in medicine are due to system errors. It's the system not supporting the fallible human. And yes, humans make mistakes, and we make mistakes about 2 times an hour, but if our systems support us, we can decrease the number of mistakes we make. One of the system changes that you might have noticed is if you go to a gas station, you cannot put diesel into a gas car or gas into a diesel car because they have changed the fittings to make it so you can't do that. And they've done similar things like that in anesthesia in medicine as well. So that's a system change that supports us as humans making mistakes, or supports us not making mistakes. So what have we learned from our study? Well, what we've learned is that family physicians, once they're taught how to do this, can see the benefit and are really good at doing it and making changes in their practices, and that they can do it without totally disrupting their practice and make the changes that improves both their practice as well as their team. Like what we found was that the team started acting, all their receptionists and their nurses and the physicians all started feeling like they were working towards one goal. And the receptionists finally had a voice to say, this isn't working for me. So not only did it benefit the patients in that they were less system errors, but it also benefited the clinics in that they were working more together as a team. So what's the problem? Well, the problem is that it's hard to convince family physicians that this is something that they should do, and they didn't know how to do it before we went into their clinics. So family physicians tend to look at QI activities as research. They don't understand the difference between the two, and they think that if they're going to start looking at their system, well, it's going to take a lot of time and a lot of energy, and they're not going to get a whole lot out of it for months, years, whatever, eons down the road. So what our issue is trying to convince family physicians who that this is a beneficial thing for them to do. Now, in acute care, you say, well, it's worked really well in acute care. The administration comes up with policies, their employees follow those policies, and then what's the issue? Well, the difference in acute care and family medicine is that in acute care you have an administration, very few institutions, and the administration that is in control of a large body of people. And they can make the policy, and their employees will follow that policy. In family medicine, so the only people you have to convince is the administration that this is a good thing. In family medicine, you have little individual practices with physicians. They're spread all over the place, and it's the physicians you have to convince that this is a good thing to do. So, how to go about doing this? And this is the question that I am struggling with right now, and I would love some help with it. So, how do we go about doing it? Well, one way to do it is to do an accreditation process, similar to what they've done in acute care. And accreditation has been tried in countries such as Australia and the UK. It has its advantages and disadvantages. I was in Australia a few years ago, and I went to 2 different accredited practices. The first one got it. They reported incidents into their own little system. They got together once a month, and they worked through, okay, how do we make it so that our system is not failing us? The second clinic I went to, accredited just the same as the first, had policies, all the policies they needed in place to pass their accreditation. But in that clinic, what happened was that it was more patient complaints that would go to their business manager who would deal with them. So there was no real clinic learning, and there was no sense that, I can improve my practice. So accreditation may have the answer, but there's some tweaks we're going to have to do with that. Well, what about looking at indicators? Can we have people like Tom Nosery was talking yesterday about essentially pay for performance? Well, what indicators do we measure? In family practice, if you start measuring all of the pap smears I'm doing or all of the hypertensives that have their blood pressure controlled properly, what about all of my psychiatric patients? How do you measure that? So what indicators would we use to ensure that people are actually following QI? So I think it's a really important thing to do in family practice. I think it's needed. Family physicians can do it once they're taught it. But my issue is, how do we convince them that they need to do this, and how do we teach them easily to do it? Thank you.